Very good evening to all respected seniors and colleagues. I'm going to present a case on CA tongue. My patient, ex-65-year-old female, residents of Danapur, shopkeeper by occupation, presenting with the chief complaints of ulcer in the lateral border of tongue for 4 months. The patient was apparently all right 4 months back when she noticed ulcer in the left lateral border, insidious onset, started with a small size like peanut and rapidly progressed to the present size in 4 months. The history of pain to the tongue, which is radiating to the ear, no history of excessive salivation, foul discharge from the mouth, no history in difficulty in speaking, chewing, but not associated with any difficulty in swallowing. The patient is having difficulty in speaking and chewing because she is not having any tooth. No history of decrease in mouth opening, no history of hoarseness of voice, no history of any loosening of tooth as she is edentulous, no history of any masses in the neck and any other oral region in the oral cavity. No history of tobacco consumption and or smoking, no history of alcohol intake, no history of any repeated trauma or sharp tooth, and since she is wearing ill-fitting, she is wearing dentures, but there was no history of ill-fitting dentures. No history of chest pain, dyspnea, nervousness. After visiting to our OPD, patient undergo biopsy and imaging. Imaging She is married with 3 children, no previous surgical illness. Patient is known diabetic and hypertension on medication since 10 years. So I am summarizing my history. 65-year-old edentulous lady presenting with non-healing, rapidly progressive ulceroproliferative growth on the left lateral border of the tongue with radiating to the left ear, suggestive first DDCA tongue.
Saumyta, just wait 1 minute. Like you have as told that there is no history of tobacco. So what do you mean by tobacco? Like, can you specify? Have you taken the history that she used to chew areca nut, or because in our region people generally chew pan masala or like pan also, and pan they don't consider it as a tobacco. Has she given such kind of history?
No, sir, she has not given the history. Even I have asked about that red color manjan that normally female use. So she has not given any such history also.
Okay, and what is her age?
65-year-old.
Okay.
And no family. No significant family history, sir.
So, like, why here family history is important, Saumyta?
Sir, few syndromes like Fanconi anemia, Werner syndrome, Bloom syndrome, in which DNA repair not possible, or Leishman syndrome P53 also one of the risk factor in which patient can have family history of tongue cancer or oral cavity cancer.
Okay. And what about her oral hygiene? Have you mentioned about that?
Not. No, sir, foul smelling discharge from the mouth कोई history नहीं है.
Why this oral hygiene history is like necessary?
Because it's also a risk factor for because if patient is chewing tobacco, then oral commensal is can also modify and it can convert into a nitrosamines.
No, that is there. That is like because before starting the cancer. But what about it once she has developed cancer? Then like why we should be considered about oral hygiene? Okay. okay, this patient is ethereal like no teeth and all, but as a general term, like once a patient has developed, suppose CA buccal mucosa or CA tongue, then in such patients, why we are so much concerned about oral hygiene and all?
It can lead to say chronic inflammation, which is also a risk.
Chronic inflammation has already occurred. That's why she is suffering from cancer. The importance or significance in your post-op care?
Post-op care, sir, it will lead to the infection or post-op wound complications.
It is not that, like there are millions of bacteria and other thing in your oral cavity, and those are commensals. They don't cause wound infection or anything like that. I think it is about like no. Most of the time you have to plan for radiotherapy and all in such patients. So you have to see like whether she is having or he is having or like a decayed tooth, and also such things should be removed before surgery, and what about the dental counseling should be done. No, because you cannot take out the tooth once you have done surgery for at least 1 year if the patient is supposed to get radiotherapy.
Okay, sir.
Okay, go on.
Hello.
Yes, sir.
Sorry, I think I am repeatedly logging out. I don't know why. So can you go back on your first slide? Sorry.
Yes, sir.
Hello. So I just want to understand your flow of history taking. What is your flow of history taking? Can you please explain your flow of history taking? How have you classified all the factors which you have taken?
Sir, main presenting complaint, lateral body of tongue ulcer, which was associated with pain.
Okay.
So pain was radiating to ear, so it was correlated.
Okay. So first symptom was pain, and you have taken history of pain. Okay. Next.
And rest patient was not having any symptoms.
What is the history? Where is the history of ulcer? Okay, you have taken history of ulcer. Insidious onset, started with small size like peanut. Okay. Point well taken. Next, did you take any history of bleeding?
Yes, sir, I have asked, but no history of any bleeding.
You have not mentioned it anywhere, right?
Hmm.
Bleeding is one history which is very important. Okay. Then next is radiating pain, referred pain, right? Read about the referred pain pathways. Okay.
Yeah. So Saumyta, like my question is, like where this disease is locating on it, which part of the tongue?
Lateral border of tongue, sir, but
Then why he is having the radiating pain the ear?
but the on examination I found ki majority of the ulcer in the ventral aspect of the tongue, which is nearby the lingual nerve.
What?
Nearby, sir, sublingual nerve or sublingual gland. That's why it's radiating to.
Yeah. So just I want to ask, like why this pain radiates with ear in case of tongue? Is there any difference in the pathway if the disease is on the your posterior aspect of the tongue, or if the disease is on your lateral aspect of the tongue? Will there be any difference in the complaint of the patient? Like, of course, in both cases there will be your radiation to the ear, but there will be something the patient will be telling you, like in which case the pain radiates to the your middle ear, and in which case it radiates to the external ear.
Sir, in this case, it will be to external ear because auriculotemporal nerve carry the referred pain.
So just as Dr. Travi has told you, like just go and read about this radiating pain. What is its pathway? What is the importance of the otic ganglion? and what is the importance of your glossopharyngeal nerve and which part. Some examiner may ask you, maybe it's very theoretical and all. Anyway, okay, go on.
Okay, so now after that you have told about local symptoms, right? Difficulty in swallowing, decreased mouth opening, change in voice, loosening of teeth. So you can start in one direction, okay, any direction, ठीक है? So difficulty in swallowing, उसके बाद फिर mouth opening नहीं, loosening of teeth, फिर और अग्रेसिव होगा तो चेंज इन वॉइस, डिफिकल्ट माउथ, रिडक्शन इन माउथ ओपनिंग, ठीक है, वेल टेकन. उसके बाद यू हैव डिस्कस्ड अबाउट एनी मास इन नेक और एनी अदर रीजन इन द ओरल कैविटी, ठीक है. तो रीजनल सिम्टम्स यू हैव डिस्कस. नेक्स्ट स्लाइड. उसके बाद गो ऑन टू योर डिस्टेंट सिम्टम्स ना. फिर नाउ अगेन यू हैव अगेन स्टार्ट कम बैक टू योर नेगेटिव हिस्ट्री of consumption. Why?
Etiological factors, sir, I have taken.
And then you have gone for metastatic factors. So there should be some flow in your presentation. Getting my point? So जो examiner है वो comprehend कर पाए what you are trying to say. There should be some story you are telling about the patient. So this patient has come, he has ulcer in mouth, okay, pain in mouth, ulcer का ये feature है, pain का ये feature है, local symptoms ये में हमने ये rule out कर लिया, regional में ये कर लिया, अच्छा distant metastasis भी नहीं है. अब क्या हो सकता है? तो ठीक है, अल्कोहल लेता था, सिगरेट लेता था, नहीं लेता था, वो सब फिर बाद में आगे पूछोगे ना. Try to maintain one rhythm, one flow, so that सामने वाला person का it becomes easier to pick what you are trying to say. Right? It should be easier for them to comprehend. So now, you know about IARC classification of carcinogens?
Yes, sir.
So tobacco is what?
Category 1A, sir.
Category 1A. Very good. Excellent. ठीक है. And any other product which people think is not carcinogen but is category 1A and very commonly consumed over here?
Areca nuts.
Very good. Areca nut is a category 1A carcinogen. So we should definitely tell people that stop eating areca nut also. Okay?
Yes.
So, Saumyta, like, can you tell me, like, what is the name of that carcinogen which is present in the areca nut?
Ericoline, sir.
No. Ericoline is not as such a carcinogen. Like, it is mainly responsible for OSMF. Any other thing? There are some areca nut specific nitrosamines which are considered to be the carcinogen.
Okay, sir, we'll read, sir.
And what about alcohol? Why alcohol is so much important? And what is its importance in case of particularly carcinoma tongue? Or maybe in PFS or anywhere?
Sir, alcohol increase the solubility of tobacco products.
Okay.
It acts as a synergistic effect on the tobacco consumption.
Okay.
So, when alcohol along with tobacco, it increases the risk 4 to 8 times as a patient is not taking tobacco or patient is taking alcohol in isolation.
So okay, you are very right. That is one thing. Another thing is also that have you wondered that why this alcohol is only causing the cancer in the tongue? Why not in the liver or anywhere? It may cause. There can be a second primary. So like many recent researchers have, like they have come to think, no, like there are certain bacteria which is found in the mouth. Okay, and those bacteria sometimes directly disintegrate alcohol or metabolize alcohol into aldehyde. Acetaldehyde, like certain like streptococcus bacteria, fusobacterium, and other things. So those aldehydes are directly like carcinogens.
Yes.
So that is just a reason, not very specific, but this is also one explanation. And you are very right. It increases, it changes the pH, and also it increases the permeability of the carcinogens. So it has both synergistic as well as direct effect.
Okay, so you told that this patient does not have a history of alcohol, no history of tobacco. Okay, and there's ulcer in the left lateral border of tongue, and she is a female. Okay, so now by these factors, what is the probability of it being malignancy than being a benign lesion? And will it be any different had this ulcer not been on lateral border and been on floor of mouth? Is there any predisposition associated with the site of ulcer, the size of ulcer? We had discussed this in our class, which we had taken on pre-malignant and potentially malignant disorders.
Pooling of sirs.
No, sir is asking you, like, what are the high risk features for the pre-malignant lesions, like which get converted into malignancy? What are like? Is there any correlation in between the size, in their location, in their consistency, color, whatever?
So that I don't know, sir. But ventral aspect of hair, that is a non-keratinizing aspect of the tongue, so there are high chances of if
That is one. Other is also like that area is very.
So, suppose there is a person who uses tobacco and alcohol. Which area of the tongue has the highest probability of getting ulcer and why?
then sir, floor of or ventral aspect of the tongue.
Why?
Due to pooling of saliva over there and chronic exposure of carcinogen at that place is more as compared to, and they are non-keratinized layer is also there.
ठीक है, perfect, very good answer. ठीक है.
Should I move to general examination, sir?
Oh, local examination. Did you do the digital palpation?
Sir, Abhi should. Yeah, I have done it.
Okay, so local examination you have
Not.
told.
Not
Okay, ठीक है. Go on.
patient. My patient is conscious, cooperative, averagely built and nourished, well oriented to time-paced person, widely stable and afebrile, ECOG 1. No paler icterus cyanosis clubbing and generalized lymphadenopathy. Uh, Local lymphadenopathy I will discuss with my local examination. On local examination, on inspection, mouth opening adequate, maintain oral hygiene, and the loss of all teeth. So this is the picture of my patient. It is a 4 centimeter around from the tip of the oral cavity and 3 centimeter from the floor of from the circumvallate papillae. Majority of the ulcer in the ventral aspect of the tongue, and it is around single solitary 3 into 3 centimeter in size and reaching from reaching in ventral aspect 1 centimeter to the frenulum. In dorsal aspect it is 2 centimeter away from the midline. So ulceroproliferative lesion, single oval round 3 into 4 centimeter from the left ventral border to ventral portion of the tongue, 4 centimeter from the dorsal aspect and the ventral aspect 2 centimeter from the tip. Majority of the lesion in the ventral portion of the tongue, 4 centimeter from circumvallate papilla, and dorsally it is away from the midline, but ventrally it is around 1 centimeter away from the frenulum. And floor of mouth is non-involved, no ankyloglossia, and lesion is not crossing midline. Normal tongue movement, patient can protrude tongue without any deviation, no visible neck masses, and no evidence of any other lesion in the oral cavity. On palpation, tenderness present, and I confirm my inspectory findings. The measurement around 3 into 3 into 1 centimeter The induration up to 3 centimeter from the tip and 1 centimeter away, 4 centimeter from the circumvallate papilla, 1 centimeter away from the midline in the ventral aspect, and in dorsal aspect it is along the lateral border only. Flora of mouth is free, patient is edentulous, jaw movements are normal, no neck, no palpable neck nodes, and I would like to complete my examination with Hopkins examination of oro and hypopharynx to look for a second primary. Systemic examination is normal. So, 65-year edentulous lady with no addiction presented with 3 into 3 centimeter indurated ulceroproliferative growth in left lateral border of the tongue, which is rapidly increasing size, no neck node. My provisional diagnosis is CA left tongue, clinical stage CT2N0. For completion of clinical stage, I need the radiological investigation also to define proper clinical stage.
What can be, Saumyta, the differential diagnosis for this condition?
It's a painful ulcer and non-healing. So, my main can be a infectious etiology, but which is very less TB or syphilis.
Yeah, so you are very right. Like there can be some granulomatous diseases also. There can be like tuberculosis of tongue, and in your syphilitic also. But by looking why this is not, so it's not looking like a syphilitic ulcer. So this is just a theoretical question. Okay. Amita, like, hello.
Yes, sir.
As you talked about second primary, you did Hopkins road examination of your oropharynx as well as hypopharynx. What are the chances of having or getting a second primary in such conditions?
So 5% of the patient can have second primary.
Is it 5 or very close to that? It is, I think, 2 to 3%, or some literature says 2 to 4%.
Okay.
So now, how will you proceed next?
Sir, I would like to confirm my diagnosis, and I would like to stage the disease, and followed by accordingly I will do my management. For confirmation of diagnosis, I will do punch biopsy or incision biopsy from the most representative area, which should not contain necrosis tissue, and for staging of the disease, I would like to do.
How do you confirm that you have taken a proper biopsy? Like how a biopsy should be done?
I will give, sir, I will do local spray at the area, lox spray, and I will take biopsy from the edge of the finger, so that, and there should be a pinpoint bleeding at the area, so that
Right. There should be bleeding so that you have not taken it from a necrotic mass.
Yes, sir. And for staging, I would like to do MRI face and neck, and for CT2N0, I would do X-ray chest for the staging of the chest.
And what about like in biopsy? Whether you will go for punch biopsy or incisional biopsy? In which condition incisional biopsy is favorable or we prefer?
If infiltrative growth is there, then sir, incision biopsy is
right.
Punch biopsy.
Okay.
So these are the radiological image of my patient, uh, which is mainly we can see ki it's very close to the lingual nerve of the region. So patient is having pain in the ear. So it is solving the query why patient is having pain.
No. Why you have asked for MRI? Why not CT? Suppose a patient comes to you who has already done a CT scan. Okay?
Yes.
A poor patient, he comes to you. Will you again advise for a CE/MRI, or you will just go for like you will go for that CT scan only?
If in case I have no doubt for that patient is not involving any floor of mouth or any structures, then I won't go for again one any new investigation. If I am not sure that I cannot get the proper margin near vallecula or hyoid bone, so we can see in CT scan also. If such locally advanced and borderline where the treatment can change with the investigation, then only I change, ask new investigation. Otherwise, we'll carry with the CT scan only.
Okay, right. Because you're very right. Because there are two things. One is your positive predictive value and negative. So positive predictive value means the sensitivity, and other one is your specificity. So almost both of them, there is not much difference if you go to the literature and books. So for CT scan also, I think it is I think 76 or 75%, and for MRI maybe 81. So there is not much your drastic difference in between these two tests. So in such cases, as you are very right, if there is no extensive disease, you feel that you have done a good clinical examination with it, bimanual examination, you are getting proper margin and everything. Then in such cases, as such, if the patient has already one investigation, then there is no need of writing another.
So this in this also we can see also proliferative growth around lateral border of tongue. It's not involving uh, mandible. And in this we can see the vallecula and is free, and submandibular gland, sublingual gland, it's like hyperechoic can be involved for this patient, sir. But in this film I am not able to see the ulcer.
Do you have a photograph of the ulcer?
In which, sir?
The photograph of the ulcer, clinical photograph, yes. So now you tell me, have we, sorry, I was logged out. So have we done the biopsy?
Yes.
Right? So from where did you do the biopsy?
From the edge of the ulcer, sir.
Okay, we have discussed this part, yeah?
Yeah, this part has been discussed. She answered it also.
Okay, I'm so sorry.
So Saumyta, like as you were talking about, CEMRI, so can you just tell me like which we go for one images as well as T2 weighted images? What is the difference in between these two? What kind of specific information these two images gives us?
T2 is for pathology, sir, and T1 for anatomy.
Okay, if you are right that T1 images like anatomical description, but anything more like in which cut we go for this contrast enhancement, in T1 or T2?
T1, sir.
T1. Okay. And how do you make out on the film that this is T1 image and this is a T2 image?
So CSF or any fluid is brighter on T2 images.
Okay. Okay. Right. Okay. Go on. So, what is your staging for this patient? Your clinical radiological staging?
Sir, it's a clinical radiological, it's T2N0, sir.
T2N0. Why?
Because size of the is around 3.5 into 2 centimeter. DOI is also, according to the imaging, it's less than 10 mm.
Okay, so Saumyta, as we have, you are talking about the staging, and I'm very sure that you have used 8th edition AGCC only, for staging. So can you just tell me about a few differences between AGCC 7th and 8th?
In 7th edition, sir, there was no DOI concept. It's new introduced in 8th edition, and external extension recently introduced in the 8th edition, along with extrinsic muscles of tongue also excluded.
Why? That is what I want to ask you. Why that extrinsic muscles of tongue have been abolished from new AGCC 8? Surbhi is there. I think Surbhi and this seminar is not just for you. Like, this is for Surbhi as well as for Rizul also. Where are they?
Yes, sir. We are here, sir.
They are here, sir. Sorry.
Yes, sir.
Any idea?
Sir, because they have taken into account, sir, the depth of invasion, sir. So extrinsic muscle involvement has been excluded from 8th edition.
Yes. One point you are very correctly. Most important thing is that it is very difficult to differentiate between the intrinsic as well as extrinsic, both radiologically and pathologically. For most of the time, like for our pathologists also, it's like once you give them that specimen, they cannot make it out very properly, and sometimes even a very small disease, but which your extrinsic muscle is not clinically involved, that you cannot make it out. Like there is no gross clinical involvement, but suppose some disease is sitting on your genioglossus, having because of its depth of invasion, so that directly becomes your disease is upstaged. So these are the two regions that your extrinsic muscles have been removed from AGCC 8. So what about neck nodes?
No part.
And okay, and AGCC, otherwise, how does it classify T1, T2, T3, T4?
T1s are less than 2, DOI less than 5 mm, T2.
So why less than 5 mm? Why not less than 10 mm? Anyone? From where has this staging come?
Maybe the muscle, the depth of external and intrinsic muscles, correlation with that.
So who gave this correlation? What was the correlation exactly?
Depending on the anatomical perspective, from where the origin and insertion of extrinsic and internal muscle comes.
No. It was just related to depth of motion. How do you measure the depth of invasion? Does anyone know what is plumb line?
Yes. One horizontal line from the base of membrane and one perpendicular line to the base of ulcer, that is plumb line.
So is it possible that the disease can have a depth of invasion less than the thickness of the disease?
Yes, sir.
Great, very good.
That
So read about the origin of depth of invasion as a part of AGCC protocol, okay? Staging protocol, okay?
Yes.
Acha, what is this, a lateralized lesion or is this a lesion approaching midline?
The lateralized lesion, but dorsally it's total lateral, but in his side it's like 1 centimeter.
So how do you define a well lateralized lesion? When do you say that it is a well lateralized lesion versus a lesion approaching midline?
If for margin we are taking, we are going, for margin, if we are crossing midline, then it's not well lateralized.
Good, very good. So basically, if the lesion is at least 1 centimeter away from midline, then only it is called as a well lateralized lesion. Okay?
Yes.
ठीक है.
So, start. Have you done any metastatic workup in this patient?
For T2N0, I did check.
Go for PET CT or not? Or in which cases we go for like PET CT examination?
So PET CT usually if infraclavicular, this is level 4 lymph node is enlarged, that is infracricoid region. If then we prefer PET CT. Or lower chances of chest mets is more, or because
one indication or there are some other. So you are right that if it is your lower neck disease, like at your level 4, another is if there is bulky nodal disease, multiple nodes are there. If it is N3B disease, anyhow, like if it is your stage 4,
yes, sir.
whether it is stage 4A or 4B, we should give. But more preference we give to the nodal disease. Okay, if there is more nodal bulk, then there is propensity that it can go up to
Media.
Yes, your distant mets can be there. If suppose you don't have PET CT at your hospital, so what you will go for?
Yeah, NCCT chest or CC.
Okay, like CT thorax, you will
Yes.
go for. Why not with X-ray chest?
Because X-ray is not that sensitive for detecting nodules less than 1 centimeter.
Yeah, the concept is same as we like. There is difference between OPG and CT scan, so it's the same as your chest X-ray and CT thorax. So there are always a chance that it may give us a false negative.
Yes.
Okay. Means its specificity is low or high?
Specificity is also low, sir. For chest X-ray, low.
Okay, read about it. Okay.
Okay, sir.
Acha, Saumyta.
Yes, sir.
So, this is clinico-radiologically N0 neck, right?
Yes.
Clinically also N0?
And radiologically also N0.
Clinically also N0?
Yes, sir.
Okay, and this lesion is a very small lesion. So what additional information did you get out of getting MRI for this patient? Could we have not proceeded without doing MRI for this patient? You did MRI oral cavity, MRI neck, and you did NCCT thorax, these many investigations. Could we just not go ahead without MRI for this patient? We'll save a lot of money for the patient.
The rule out second primary is also needed.
Okay, good point. Good point, second primary. Anything other than that? For second primary, you can do your endoscopies and all, right?
Yes.
And what is the incidence of second primary? Are we ruling out second primary in all the cases every time?
We should rule out, sir.
So, what is the incidence of having second primary?
2 to 4%.
Over a lifetime of?
Lifetime of
20 years.
20 years.
है ना? The incidence is not that high of having a second primary, right?
Yes.
So now from other perspective, can we go ahead without doing an imaging in these kind of patients? So what is the probability of this patient being pathologically N plus?
T2 has a issue. It's more than 20% focal.
more than 20% तो ठीक है, but more than 20% is 80% also, 40% also, 60% also, 25% also. So,
20%.
huh?
20 to 40%.
Very good answer. Perfect answer. Nobody can contest this answer. So, see. So we have to know that approximately 30% of the patients who are clinico-radiologically N0, they might be harboring some metastasis, right? So now the question is, can we detect these metastasis? What is your line of management for this patient? What will you do for this patient?
I will doing type glossectomy for this patient along with selective node dissection of level 1 to 4.
So you said that the neck it is clinico-radiologically N0, right? Then why are you doing neck dissection for this patient? Leave that neck apart, no? Just do tongue and go out. There is no disease. Patient will say, why are you operating my neck, doctor? I don't have any disease over there.
Sir, if chances of occult more than 20%, then we should address neck.
What is the survival benefit of that?
Said who and why should we operate if chances of occult metastasis are more than 20%? Why? I would say no, if the chances are more than 30%, then we should operate. See, you have told this statement twice, then you should know that the evidence and the logic behind it. Otherwise, don't utter it.
According to N0 neck trial, Anil de Cruz's.
So that paper does not talk about 20%, right? That paper is Weiss et al. WEISS, where they have shown a proper advantage in survival of if that metastasis is more than 20%, right? But now, coming on to Dr. D'Cruz's paper, what did that paper say?
They have he has compared elective node dissection versus recurrence second setting neck dissection. If neck node is coming in future, then he has done neck dissection comparison arm. So it shows elective node neck dissection is a better OS benefit as compared to later dissection.
No. These are not his two arms. Please read it because this question will be asked to you in the exam if this question paper comes. Okay? So do read N0 trial properly. So they had two different arms, right? But one arm was elective neck dissection and the other was therapeutic neck dissection, right? Therapeutic neck dissection means what?
Therapeutic neck dissection, sir, if
it is clinico-radiologically positive, whenever it is clinico-radiologically detected, you then operate, right?
Yes.
What was the difference in survival between these two arms? What was the primary outcome of this study, primary endpoint?
morbidity is less.
Morbidity? No.
What is the primary endpoint? What is the secondary endpoint? And what is the difference between primary? In general, do you understand? So, what is the difference in the meaning or interpretation of primary outcome versus secondary outcome? If a study is being done and you take a primary outcome and you then take secondary outcomes, so are all these outcomes significant?
So I will read. I will read, sir.
Okay. So read N0 trial. Okay. We had a very good presentation on N0 trial in our department. I don't remember who had presented, but this was a very good presentation on neck dissection in which N0 trial was covered. Okay. So the next question is that see, understand the philosophy behind it. The aim of doing neck dissection is twofold over here. One is giving therapeutic benefit to the patient, which help translates into difference in overall survival and disease-free survival, and the other is a diagnostic benefit. So when you do neck dissection, you know that. So how do we know that there's 30% chances of occurred metastasis? Because when we operate and when send these samples for analysis, and it is done, there's histopathological examination is done. There, in that analysis, we see, okay, out of 100 of these patients, 30 actually have metastasis, right? So this is not only therapeutic, it is also diagnostic. And since it is a diagnostic, it also helps us in deciding further adjuvant treatment plans, right? And all of these have an implication on survival, right? So our aim is to identify those 30 cases and give them the survival benefit, because 70 are still going to be N0, right?
Yes.
So is there any method by which we can try to minimize or maximize that number, which means that we can detect maximum patients who have metastasis and exclude maximum patients who don't have nodal metastasis? Is there an upcoming modality which is being talked about a lot?
Sentinel lymph node biopsy.
Perfect. Beautiful. Beautiful. So what is sentinel node biopsy? Surabhi?
So biopsy from the first nodal basin, sir, where the primary tumor is draining, sir.
Those who are called as
Okay, we'll talk about sentinel node biopsy in detail in some other class. No? Sorry. You can proceed, Dr. Saumyta. Huh?
Presentation is over, sir.
अच्छा हो गया. Perfect. Very good. So, anything else that you want to ask, Dr. Kunal?
yes. So like it. What kind of surgery you will be doing? Some in this case.
Sir, type 3 glossectomy.
What is type 3 glossectomy?
Hemiglossectomy is type 3 glossectomy.
Like, is there any your type 3A, type 3B?
Type 3B is compartment when floor of mouth is involved along with the tongue, then we are doing compartment dissections.
You want to do a type 3A?
Yes.
Not compartmental. And what do you mean by compartmental resection tongue?
You are removing along with genioglossus.
Just in one line, you describe compartment. Compartment is not only for tongue; it can be for other organs also. We call it compartment. This term is used. So, Survi, what do you mean?
Bundle along with
all neurovascular as well as muscular bundle. Oh, yes. That is moved in toto. So, concept of compartment resection is nowadays a very hot topic in CA tongue. Why? Yes. So the main concept is that there is an emerging concept of metastasis in transit. Have you heard about it?
In transit metastasis.
Yes, in transit metastasis. So what happens now? There are small or very small tumor emboli or your nodal emboli, and those passes through your floor of mouth area. Okay, and but they are not easily diagnosed radiologically also. Sometimes even on MRI also, those are missed. So these emboli are found mainly along your lingual artery, and there are certain nodal stations which we call lingual node, as well as along the hypoglossal nerve. And there are a few papers. And why this? Like, who has propagated this concept of compartment resection? And quote some paper. Just think about mental dissection of calabresi and all.
Calabrese.
Yeah, but this is not well accepted thing. Like many people say, no, this is like there is no much benefit of doing it. Some say no, we should go for it. So it's still a matter of dispute. Okay, so what will be your reconstruction in this patient?
For this patient, sir, if microvascular surgery facility is available, then radial artery forearm flap will be.
Noted. How do you define or how do you plan your reconstruction in case of carcinoma?
Sir, if less than 30% defect is there, then primary closure and is also acceptable. Until and of is free. Because tip of tongue is important for speech.
So the concept is that if less than one third of like you have done defect is less than one third, then primarily amenable. We can close it primarily. If it is more than one third but less of, then in such case also some people put flap, some may not. And that if it hemiglossopathy or more than, then definitely it should. So what are the options like?
So I have one objection to what Saumyta said. May I?
Yes.
So Dr. Saumyta, you said that you want to operate this patient. It's a small tongue, beautiful tongue, N0 neck. I think you want to operate because you want to generate revenue for your department and your hospital. Why didn't you send this patient for chemotherapy and radiation or radiation alone?
But for operable lung cancer, there is no overall survival benefit.
Says who? Who said this? Hello?
Zong et al. And etc. et al. Sir.
Okay, point well taken. But what did they say? Did they compare operable tongue versus, and they gave radiation versus surgery? What was their trial, etc. and Zong?
They did sir NACT for operable oral cavity cancer and gave then followed by surgery.
So where is radiation in that? Zong was 10-year follow-up of Licitra, right?
Yes, sir.
But they are not talking about surgery versus radiation. They are just comparing the role of or the advantage of giving neoadjuvant chemotherapy in operable oral cavity cancers, and what they tried to look at was organ preservation, and actually they saw that there was around 21% mandibular preservation in cases where mandible was not directly involved, right?
In paramandibular disease, if you want to preserve mandible, it can be the procedure.
Yes, but we are not talking about that. What I am saying is, why do you want to operate this patient? Why not upfront send to Vinita madam or Rita madam or Richa ma'am and get this patient a good quality of life with chemotherapy and radiation?
The CTRT is also.
CTRT is?
CTRT is also not a good choice for if T1 lesion, and for that RT is comparable to surgery.
Says who? Where is your evidence for this? From where are you saying this? That for early T1 lesion, RT is equivalent to surgery? Can anyone back her up? Please help her. Anyone, Rizul, Surbi, or who else are there? Dr. Nirdum, Dr. Savita, Dr. Latasvi, Dr. Brahmanand, Dr. Abhi. So read about it, okay?
Yes.
Why are we operating oral cancer patients and not giving radiation and chemotherapy to them? It is a very important question. When you are operating, whatever treatment decision you are taking for the patient, you have to know why. What is less important? Why is more important? If you know why, you can change your treatment decisions. You can modify your treatment decisions. If you focus on what, it will be difficult, right?
Yes.
Try to find out why about each and everything, है ना?
Yes, sir.
कुछ और डॉक्टर कुणाल?
Last question, Saumyta. As we have been earlier doing like PMMC flaps also, or maybe some loco-regional flaps for tongue reconstruction, what are the disadvantages? Or if there are some advantages, can you illustrate those things? Like why a free flap is the best option in case of CA tongue? Why not PMMC flap?
Sir, since PMMC, we are there is a
What?
pull is near matlab in the gravity. The patient
Taken, okay.
not, which is free mobility is there after free flap.
So yeah, so the concept is that like should be replaced by like. Okay. One issue is your reach of this PMMC. Second, you are very right. There is some dragging because of this gravitational pull, and this flap will be pulling it down. Second and third is that mobility of tongue is hampered. Okay, because the main purpose of tongue is it helps you in chewing and swallowing. Okay, so those things are hampered. So in this era of free flap, wherever possible, we should give the patient that option of free vascular or free flap reconstruction. So Saumyta, well presentation. Okay, I think you are studying hard for your practical examination. So, but as Dr. Ravi has asked you to read about few more things, go through those papers, go through those your trials, specific trials, N0 trial. Why not? Where to use brachytherapy? Why not brachytherapy? What are its advantages? When to choose it? What is patient factor? What is tumor factor? And which modality for what tumor? So these are the things which you should read out.
Okay, sir.
And also, do you read about what adjuvant treatment will you give in these patients for what histopathology and why will you give that treatment? Because I think our discussion is yet pending, but we have already crossed 1 hour and you guys have to study a lot.
Yes,
And, so I think we can call it a day now.
yes, right. Okay.
Thank you, sir.
Thank you, Dr. Saumyta. Well presented. Keep it up. Keep putting an effort.
I think next presentation should be